Hello again, everyone. Welcome back. We will now discuss when to start pharmacologic therapy and setting the end goal for managing hypertension in the elderly. When do you start pharmacologic treatment, and what are the goals in the elderly population? We previously discussed three general guidelines given by three different professional organizations. Please see the accompanying table. They include the American College of Cardiology / American Heart Association 2017 guidelines, the American College of Physicians, and the American Association of Family Physicians 2017 guidelines, and the European Society of Cardiology / European Society of Hypertension 2018 guidelines. Please take note of the American College of Cardiology / American Heart Association 2017 guidelines, which defines older patients as greater than or equal to 65 years old, blood pressure threshold for initiation of pharmacotherapy greater than or equal to 130 over 80 millimeters mercury, and a blood pressure target of less than 130 over 80 millimeters mercury. The American College of Cardiology / American Heart Association guidelines, which is based primarily on the SPRINT trials, separated the blood pressure threshold for the diagnosis of hypertension from the blood pressure threshold for initiation of pharmacological treatment. In most patients, the blood pressure threshold for initiation of pharmacotherapy is distinct from the on-target blood pressure. High-risk patients qualify for antihypertensive drug therapy when blood pressure is persistently greater than or equal to 130 millimeters mercury systolic and or greater than or equal to 80 millimeters mercury diastolic. The on-treatment target blood pressure is less than 130 over 80 millimeters mercury. High-risk patients include those with diabetes, chronic kidney disease with an estimated glomerular filtration rate of less than 60 millimeters per minute per 1.73 meters squared, and or urine albumin creatinine ratio of greater than or equal to 300 milligrams per gram. Post-renal transplantation, heart failure with reduced or preserved ejection fraction, known cardiovascular disease, peripheral arterial disease, and or greater than 10% 10-year atherosclerotic cardiovascular disease risk. The 10-year atherosclerotic cardiovascular disease risk calculator can be accessed at www.cvriskcalculator.com. Secondary or non-lacunar stroke prevention in antihypertensive drug-naive patients is the only high-risk comorbidity for which the 140 over 90 millimeters mercury treatment initiation threshold is recommended. The on-treatment blood pressure target is, however, still less than 130 over 80 millimeters mercury. Lower-risk patients under 65 years of age, defined as those without the aforementioned high-risk comorbidities and 10-year atherosclerotic cardiovascular disease risk of less than 10%, are recommended for antihypertensive drug therapy when blood pressure is greater than or equal to 140 over 90 millimeters mercury. Similar to most high-risk hypertension, their target blood pressure is less than 130 over 80 millimeters mercury. In non-institutionalized, even frail community-dwelling adults aged 65 and older qualify for drug therapy when systolic blood pressure is greater than or equal to 130 millimeters mercury. However, no diastolic blood pressure treatment threshold or target was given for this group. Target blood pressure is less than 130 millimeters mercury systolic. Considerable restraint regarding the intensity of antihypertensive drug therapy should be exercised in older persons with life-limiting medical conditions. In a prospective study done in Italy, 1,111 non-diabetic hypertensive patients with a mean age of 67 were randomized to receive open-label antihypertensive treatment to lower systolic blood pressure to less than 140 mm mercury in one group and less than 130 mm mercury in another. The primary endpoint was the incidence of left ventricular hypertrophy after 2 years of follow-up. The study shows that patients who were randomized to systolic blood pressure lowering to less than 130 mm mercury had less incidence of left ventricular hypertrophy compared to those randomized to the systolic blood pressure goal of less than 140 mm mercury, 11.4% and 17% respectively, with a p-ratio of 0.013. The difference in systolic blood pressure achieved after the 2-year follow-up between the two groups, however, was only 3.8 mm mercury, so the effect of choice of antihypertensive medication may have influenced the result. The action to control cardiovascular risk in diabetes blood pressure trial, also known as ACCORD-BP, involved 4,733 middle-aged and elderly participants with a mean age of 62 years with type 2 diabetes mellitus and established cardiovascular disease, evidence of target organ damage, or at least two cardiovascular risk factors. They were randomly assigned to a 2 by 2 factorial design to intensive with a goal of systolic blood pressure of less than 120 mm mercury versus standard with a goal of systolic blood pressure less than 140 mm mercury blood pressure control. Antihypertensive medications were given open label, and the study did not specify the drug class that would be used to lowering blood pressure in both groups. After a mean follow-up of 4.7 years, the blood pressure decreased from a mean of 139 over 76 mm mercury in both groups to 119 over 64 mm mercury in the intensive blood pressure lowering group and 133 over 70 mm mercury in the standard control group, which resulted in a 14 over 6 mm mercury difference between the two groups. As expected, those in the intensive blood pressure lowering group were on greater numbers of antihypertensive agents. There was no significant difference between the two groups in the incidence of major cardiovascular events, which include the composite of non-fatal myocardial infarction, non-fatal stroke, and cardiovascular deaths. Furthermore, there was a higher incidence of adverse events in the intensive treatment group that are attributable to antihypertensive therapy. These adverse events include hypotension, syncope, bradycardia, and arrhythmia, as well as hypokalemia and elevations in serum creatinine. On the other hand, there was a significant reduction in the incidence of total stroke and non-fatal stroke, which are two of several pre-specified secondary outcomes in the intensive blood pressure control compared to standard blood pressure control group. The ACCORD study, however, is limited by the low occurrence of cardiovascular events during the study duration in the standard control group. This may have minimized a probable differences in outcomes, if any, between the two groups. Nevertheless, the ACCORD results, while showing that systolic blood pressure lowering to less than 120 mm mercury reduced the risk for stroke, did not support further lowering of systolic blood pressure beyond 140 mm mercury in improving cardiovascular outcomes in middle-aged and elderly hypertensive patients with diabetes and may in fact lead to a higher incidence of adverse effect related to treatment. However, the SPRINT trial seems to indicate that this may not be the case for non-diabetic elderly patients and older patients with kidney disease. It therefore seems that antihypertensive goals in the elderly with diabetes should not lower systolic blood pressure below 140 mm mercury, as this does not improve cardiovascular outcomes and may in fact lead to a higher incidence of adverse effect related to treatment. This ends our discussion on setting goals for managing hypertension in the elderly with medications. See you next time when we discuss selecting antihypertensive medications for the elderly.